You are watching a special edition of the Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. We're breaking news today with a desert first. My first guest is Dr. Roland Reinhart. Dr. Reinhart is the founder and medical director of the most comprehensive pain center in the Coachella Valley. We've invited him on the program today to discuss new techniques to treat a wide variety of pain. Dr. Reinhart, welcome to the program.
Well, thanks for having me.
New technology, right?
New stuff.
You're the first one. You're the first one using this.
We have a number of new techniques that are being used that are actually helpful, and I've often said that there's more options. You know, every year there's more options, more ways to treat pain, and there's a lot more exciting things that are happening.
Okay, pain. I mean, that's still all you do.
Correct.
Over 50 employees. Is that right? I mean, that's a serious pain center.
We have a large practice. We have 5 practitioners, and all of our employees, you know, we're all focused on just doing pain management.
Now you have a physiatrist now, medical doctor, Dr. Ruth Anderson. We've had on the program as well,
right,
medical doctor.
Right.
She's always great.
Right.
She's lovely to have on the show. And so are you treating more things than before? More comprehensive? I mean, we say comprehensive, but what does that mean?
Right. Actually, with the addition of Dr. Buffard to our practice, who is a physiatrist, we're able to expand kind of the capabilities to diagnose. I mean, that's really part of what has gotten so much better, is the ability to diagnose the precise causes of pain, and then to apply treatments that are specific for that with the least amount of interference. I mean, our goal is not just, you know, to get you out of pain, but also to get you back in function. And with Dr. Anderson's background in exercise, Dr. Buffard as a physiatrist, I mean, it's great. There's a nice continuum from diagnosis, elimination of the pain, and then return to function. So it's just been great.
So better diagnosis.
Better diagnosis.
Finding where the pain's coming from.
Exactly.
So you're better today than you were 5 years ago when we first had you on the program?
Yeah, 5 years.
I mean, much better?
Well, yeah. Well, every year things are getting better. I mean, technology overall in all areas of medicine and in all areas of life are getting better. I mean, look at your iPod. So there's things that are just improving all the time, and so our ability to take those tools, apply them, find the cause of the pain, and then eliminate it, those things have all gotten progressively better. Okay,
now we've talked on the phone. You want to bring awareness to the Coachella Valley. You're still convinced that there are a lot of people out there that are in pain that don't have to be.
Well, that's true. I mean, there is, you know, every day we have people come in and they've been suffering for a number of years. I saw a fellow the other day. He had been in pain for 5 years. He was told 5 years ago, there's nothing we can do for you. And, you know, 5 years ago, maybe there wasn't anything that could be done for him. And I think also, you know, pain is still a fairly new field, having just been born in 1993 compared to other fields. And this person had gone and they'd seen surgeons, and the surgeon said, there's nothing I can do. Well, surgically, there probably isn't anything they can do for them.
So if 3 years ago they were told, possibly, there's nothing we can do other than your current treatment, they need to get another opinion.
Well, I think getting new updated evaluations, and it also depends on who they were seeing. I mean, for instance, you know, the family practice, or depending on who, you know, there is so much that's going on even in those fields. New antibiotics, new antihypertensives, they have so many things to focus on. If a patient comes in and maybe they're elderly and they say, well, I have pain in the morning, or I have pain here and there, you know, quite often we have patients come in and say, well, my doctor just told me I was old, you know. Well, we're all getting older, but there are things that can be done about that just to improve the quality of your life. And that's really what we focus on, is elimination of pain and return to function. So.
Okay, but so let's move into what's new. I mean, some of the new techniques, and we, you know, made a bold statement. We say the desert first. Let's start with the new technology. I mean, what's new that nobody else has? Well,
there's a number of technologies that are in large part improvements on old technologies. There is, for instance, for a number of years, probably a couple decades now, there has been the ability to do spinal cord stimulation and to block pain. And a spinal cord stimulator, it's like a pacemaker for the spine, and the patient can control that. You know, Medtronic, one of the largest and well-known company, has great support for their products. You know, has been making this for a long time, and they make pacemakers for a long time. But there's some other smaller companies that have come out with new technologies and improvements on that technology. So we use some of the newer systems from, for instance, Advanced Bionics, and they have the capability to cover pain that perhaps the Medtronic system wasn't as good at, like low back pain. So if we can capture and eliminate pain electrically, not having to use drugs, that's a big improvement in the quality of people's lives. And so, those technologies keep improving.
So I understand this electronic stimulation. Okay, so it's an implantable device, no drugs, and it stimulates a nerve or something. But how is it eliminating pain with stimulation? What is it doing? Redirecting the pain?
Well, realize that pain is actually just totally sensed in the brain, but there are receptors in your body that send signals to the brain. And what a spinal cord stimulator does is to change that signal that's going to the brain from one of pain into one of a nice, warm, tingly sensation. And so we can actually tell the brain, from the receptors at the periphery, hey, everything's great, feels good. And actually, there are other health benefits in that doing that stimulation actually helps to improve blood flow into lower extremities. And in Europe, that's one of the greatest uses for this technology, is actually to help people with peripheral vascular disease.
So what, in these stimulators, what type of pain or what kind of problems does it work best for?
Well, it works, the best ones, the classic use for this has been people who have pain in their back and down their leg, for instance, sciatica, and perhaps people who have had previous spine surgery. Or yesterday I saw a gentleman, he was 85 years old, his spine, he obviously is a very active guy, but his spine has a lot of disease, and the surgeons, when they look at it, kind of go, you're looking at 8 to 10 hour operation here, and maybe their cardiologist says, we're not so sure you're going to make it through surgery. So this is something that could help eliminate that pain.
And so sciatica and low back pain.
Sciatica and low back pain.
But where does the pain have to originate in order to qualify for this?
It doesn't really matter where the pain originates from, right?
The things we're talking about today, insurance covers.
Correct.
Everything we're talking about. Okay,
correct.
So back to these stimulators. This is the next generation. You're saying it's a better stimulator than it was a couple of years ago.
Well, it is.
Because it's more precise, more targeted. What is it?
Well, it allows for increased spectrum so that back pain is better covered. The old technology, you'd say, well, if you have pain down your leg, that's really what you have to have. And with this stimulator, you actually can get back pain coverage with the new stimulator.
So broader indications now?
Broader uses. Broader uses for this type of therapy. So,
but it sounds like, Dr. Reinhart, that since thousands of people in the Coachella Valley have low back pain and sciatica. Are they all candidates for this? Because you're saying it works well for low back pain and sciatica.
Those two problems often go together, because as you get
no
sciatica,
drugs.
It's deterioration. Correct.
Well, it's no. Well, if I'm understanding correctly, unless I'm missing something, it seems like everybody should do this.
Well, it's a very elegant way to control the pain.
I don't want to be salesy here, but again, if it works, if it's effective, if it's not a drug, and you're just stimulating the nerve to change the signal to the brain, logically, it sounds like everybody should look into it.
Well, it's something to look into, and it's something that can be beneficial. Again, what's
the big but, though?
As we discussed
what could the
earlier,
critics say about it?
Well, the downside to it is you're having something implanted in your body, and you're having to have surgery. Okay, it's a minor surgery. It basically can be done with local anesthetic. Mm-hmm. But you still, the reason we're not running out and implanting these in everyone is a lot of times you can get rid of the pain with much more conservative measures. So these are kind of the more advanced techniques for people who have failed everything.
Okay.
But there are other techniques, and again, as we get better diagnosis,
do you think it's fair for the patient? If it was your own mother, is it fair that a patient has to fail everything else before they get exposed to this kind of therapy?
Well, it depends.
Is that what the insurance companies want? They want you to try these other things first?
Well, there's always issue with insurance companies, but these are always paid for by the insurance companies.
Okay.
So, and in addition to which, if you had to think about, well, you're going to implant me. Even if you were going to have a pacemaker, if you could have something else done that didn't require surgery.
Are there fears? The patients are a little bit afraid of this?
We haven't really found anyone. Mostly these are patients who have failed a lot of other therapies. And the amazing thing is, if you take that jump in technology, then all of a sudden your life's better. So people might be afraid of, cell phones or something, when they first came out. Okay. Well, now it's just an everyday thing. Nobody's afraid of them. It's the same thing. It's a leap in technology, but if you make that leap, it can be very beneficial to you. And then you find that your life is a whole lot easier.
Okay, somebody watching this, they're in pain, they're thinking, okay, well, it sounds good, no drugs, electronic stimulation. What's the downtime? What's the process? What can they expect?
Right. Well, with this particular technology, you actually try it. That is, we put in a wire and you test it for about a week and see if it does for you what we expect it should do for you.
What are they saying, by the way?
Well, we're getting very good results.
Like 80–90%? Where they say I feel a lot better?
Anything over 50%, although typically we see 75 to 90% improvement.
Okay.
And again, these are people who, this is if you come to our office and you say, hey, I saw that thing on the show, and why don't we just put one of those in? We're actually going to evaluate and see if there's other things that can be done to eliminate your pain. So this is kind of the high-end, cutting edge.
But if that
newer
happens,
technologies.
what's wrong with that? Oh, you just want to caution these people that you want to try other things first before you do an implantable device.
Well, if you can eliminate pain without having to implant it or have it take somebody's surgery, I mean, again, we're going to use the most conservative measure to eliminate your pain. And if you don't have to have surgery, why would you want to have surgery? So, but again, these would be the newer technology, newer edge type things that would be done that really can improve the quality of people's lives.
Okay, now I interrupted, but downtime in the process, you say they try it for a week.
Right.
Then what?
So you try it for a week. If that seems to be a benefit to you, then we actually implant it. The downtime is really probably not more than just a few days. And by downtime, you're up, you're walking, you're fully functional. It's just you may be a little sore. You may be a little sore at the surgical sites typically.
And so they're out. I mean, the surgery itself takes what?
The surgery itself probably takes maybe hour and a half.
And they're going to get pretty good. The anesthesiologists there are going to be some of the best in the world.
Well,
I mean, because that's what you do.
Well, we have good anesthesia, but actually for this we don't really use a lot of anesthesia.
Oh, really?
Yeah, it's really done with local, because as we put it in, we want to stimulate and ask the patient, how does that feel? Does that seem that that's covering the area where you have your pain, and so on. So,
is this the future of pain management? I mean, as they're figuring out how to target these nerves to change the signal to the brain?
Well, this is very elegant because without drugs, you're just changing that signal. But in terms of the future, I think that there's improvements in things like cold laser technology.
Yeah, let's talk about that. We're going to take a quick break. You've got this cold laser that targets pain. I'm not sure how it works. So when we come back, we'll talk about that. You're watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. We're talking about serious pain management here with Dr. Roland Reinhart. We'll be right back. You are watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. We're breaking news today with a desert first with technology for pain patients that want to get out of pain. We're here with Dr. Roland Reinhart. Dr. Reinhart, and we've talked about electronic stimulators without drugs. Let's talk about laser technology. And you're using lasers in your practice.
Correct, yeah. We've been using laser for about 2.5 years now. And
what's it called, by the way? Cold light laser?
Well, some people call it cold laser. It's laser light, which is light that's going to penetrate into the body. And because it's pulsed laser light, it doesn't heat up the tissues. Unlike lasers that are used by the cosmetic surgeons, where they're actually trying to burn off the skin or whatnot, those actually have the impact of the energy at the surface when they hit the skin. So these lasers, though, actually are pulsed, and they basically allow the energy to penetrate into the cells before the energy is released to actually activate the cells and help repair cells.
So it helps the body heal itself?
That's exactly right. Actually, the studies show that you have improved healing. You also have decrease in inflammation, decrease in pain related to the decrease in inflammation, and just improvement in the cellular function. Okay,
if you're just tuning in, brand new topic here with Dr. Roland Reinhart. We're talking about electronic stimulators without medication, and now we're talking about the new lasers that are available. So who's a candidate for this? Because people will say, okay, they're sitting here watching this, well, would this be good for me?
Right. Well, the people that seem to do the best with it are people who are suffering from an injury that may cause swelling and inflammation. So if you have longstanding arthritis, or if you're bone on bone, probably not really going to help you very much. But if you have an injury that's providing some swelling and has some soft tissue component to it, then those people seem to do very well with the laser with rapid improvement. And the nice thing about it is, as we discussed earlier, you were questioning earlier, is what's going to be the new edge in technology. Well, these may be it. But
does it work?
It works very well.
I've seen the procedure, and I'm very skeptical.
It works very, very well. Well, you should wait till you're injured and have it done.
Okay.
It works very well.
Thanks for wishing that on me, Dr. Reinhart.
It'll break a leg.
Okay. Well,
so it works very well. Again, with the right patient, right selection of patient, and again, having good diagnosis.
Are there those laser miracle stories where people say, where you're surprised that the laser did something?
Yeah, absolutely, absolutely, and in many conditions where there may not be much hope, such as their neuropathies or whatnot, may get very good results from laser. Depends on the cause of it.
Are there those patients that you've seen and treated that this was
absolutely
surprisingly
and
effective?
Absolutely, and patients you wouldn't think, well, we can try this if you want to. Maybe they're afraid of an injection or afraid of taking pills. I mean, pills is while a lot of medicine is about pills and so on, if you can get away from using pills, which essentially are affecting the whole system. Now, if you have pain throughout your whole body, well, pills are a good way to go. But most pains, most injuries that people have are localized. And again, if you can get the diagnosis, define that very precisely, what the pathology is that's going on, and then apply the correct treatment. And the great thing is having so many different options and so many different therapies to apply that problem, that we can eliminate the pain, and again, to get patients back to function, so they get back to playing golf, out dancing and whatnot. So
now, I had your physiatrist, the medical doctor here, and Dr. Ruth, and he's brand new to the Coachella Valley. And I said, what? I asked him, if there's a problem the way pain management is being practiced in the Coachella Valley, what's your impression? He said, I think they're being under-treated, under-medicated.
Right. Right.
You still think this?
Well, always have thought that, and the studies would show that people feel that they're undertreated. But I think that
you could just say it like it is. Go ahead. I mean, how do you really feel here?
Well, I think.
Are they undertreated, under-medicated for the most part, pain patients?
Well, under-medicated perhaps quite often of their own choice. I mean,
yes,
it's not necessarily
so
the physicians.
They are under-medicated for the most part?
Well, if you're having pain and your pain's getting, on a scale of 0 to 10, over a 5, even for periods of the day, there are things that can be done to eliminate that. And even if you're just having some discomfort that's keeping you from, functioning as well as you can.
But it's not necessarily the fault of the physician, the primary care physician. Obviously, maybe the pain patient is kind of a gripey patient, I've been told, or maybe they're not being managed properly. They're not going to a specialist, it sounds like, oftentimes.
I think that the specialist, just like the specialist in anything, family practice or internal medicine is such a broad field, and there's so many other things to keep up. I mean, if somebody had to deal with you having a heart attack versus, you have pain going down your leg, obviously the heart attack is a life-threatening problem.
Okay.
You'd want them to focus on that.
Does the internist send you patients?
Oh, absolutely.
Okay.
Absolutely, yes. Yeah, we have a broad base, and what I'm really proud of is probably the biggest referral base we have is from patients we've already treated. And
they don't need a referral from their internist or their primary care physician to see you, a specialist.
Don't have to have that. That's correct, yes. That's right. They can call up and we'll make an appointment. There's a lot of people, because we have a lot of people who come from out of town, and maybe they don't have a primary care doctor here. If they need a primary care doctor, then we'll refer them to a primary care doctor.
One of the things you always say is that you treat pain as an emergency.
Right.
Not just a slogan.
No, and that really
is this a philosophy of yours?
Yeah, it really comes from my parents' experience with their doctors at home. And they'd be at home, they'd be coughing, they'd run a fever, and they call them, maybe they couldn't get in for a week or two, and it just, I think pain is one thing that really drives people to seek medical attention. I mean, even if you have the flu, if you're coughing, your chest hurts and so on, that would drive you to call your doctor and so on. So we look at pain as an emergency, and so as a result, pretty much every day we have 10 or 12 patients who call up and say, hey, I really need to see you today. And so it's, a feeling as we want to take care of them.
What do you say to people that say, and I talk to people and people talk to me and they'll say, well, Dr. Reinhart's just putting a Band-Aid on the situation, or he's just throwing drugs or medications or procedures on the situation. What's your response to that? Right.
Well, I would say, again, earlier I said there's no cure for things. I mean, if you have something that's happened to your back or your spine or your legs or whatever, there's most frequently not a way to make it like it was. Even if you do surgery, it's never like it was. So in terms of people saying, well, you just put a Band-Aid on, well, again, we try to use the smallest Band-Aid then that there is to bring about the best improvement there. And frankly, using things like steroids or whatnot to inject, if you can get the inflammation out, get the pain to go away, we are actually helping the body to bring about maybe a faster process in the normal healing of the body.
Okay, good. Now, people watching this, and I know you don't want me to mention this, but you say that if somebody watching this, they're in pain, and they call your office, they're going to see you that same day. But, I mean, they may have to wait a long time in your office, but they could see you the same day.
Well,
is that right?
Most frequently, I mean, if there's no reason not to get them in, and again, we have a number of providers, and we've added more providers. It seems like every year.
Other physicians in your practice,
right? We've added more physicians, and pretty much we're able to do that. And
what about the wait though? Somebody could say, "Well, I had to wait at Dr. Reinhart's.
Well,
I feel better, but I had to wait."
Right. Well, you can stay at home and have pain and wait for 3 weeks to get an appointment and get in and out. Again,
is that going on? By the way, a pain patient calls and it takes 3 weeks to get in.
Well, in a number of places, yeah, that's true.
Not at your place.
That's true. Not at our place. Not at our place.
And you still meet with the patients?
We do.
You? I mean, how do you divide them up? Yes. I mean, people see Dr. Ruth on the show. They see your physiatrist on the show. You just divide it up?
Right. Well, if they have a specific request, or even internally, we will put people. Perhaps there's someone who has more of a problem with exercise or fitness or something like that. I probably would see if Dr. Bouffard would see that patient. So,
okay.
And during the day, we're very efficient with seeing our patients, and so it may not seem that way when you're sitting there for an hour, but actually we improve our efficiencies in terms of if Dr. Ruth is doing procedures, I'll be seeing patients. If I'm doing procedures, she'll be seeing patients. So it may depend on what time your appointment is and so on and so forth. And
now physicians, and we're just about out of time. Physicians watch this program.
Right.
What do you want them to know about you, or other health practitioners? What do you want them to know about you? Maybe there's some misinformation out there, misunderstandings about you. What do you want them to know?
Well, I look at our practice as really the support arm to the other physicians. So my job is not to somehow do something that they do. There's no point in my doing that. And quite frequently patients will say, well, can you give me an antibiotic for, they have a cold or something. Typically, we'll refer them back to their doctor, or we may call their doctor, ask them, would you like for us to put your patient on a medication, and they can follow up with you. So we really are kind of a focused support arm for the other physicians, and essentially, hopefully help with an area that has become increasingly complex, and physicians now are doing CME credits and so on, but there's only so much you can learn there, and that information keeps changing. It seems like on a weekly basis, which drugs are most helpful, what's new that's come out, and so I think that we really function best as a support for those physicians.
I've been told by a physician that the way it's set up, sometimes people are put on a pain med and they're on it for the rest of their lives, if they're feeling okay. But now there's newer drugs, I guess longer acting drugs. So tell me about some of the new things. What do you say to those people?
Well, yeah,
they've been on the same medication more than 5 years or whatever.
Right. I mean, we've seen people come in and they're on, Vicodin, have been on Vicodin for the last 5 years. And, there are better drugs that can give them better pain relief. And again, it's kind of, it must be very difficult. I can't imagine how difficult it must be for a primary care doctor who's dealing with a number of issues which are perceived more important in terms of the patient's health. But the patient comes in, and they've been on a drug and they're not really complaining about it because that drug's doing it. Mm-hmm. But there may be better uses of that drug. For instance, Vicodin is a fairly short-acting drug. So these patients, typically they might take a dose before they go to bed, mm-hmm. but then as they sleep through the night, the medication's completely gone. So there are drugs that actually can improve them so that they don't have to wake up in the morning with so much pain.
Why aren't they being told? Just not enough time?
Well, I think that's part of it.
Or if the patient doesn't complain to their doctor because they think this is just the way it is.
Well, I think if they feel that, and we often get patients.
If somebody watching this on Vicodin for 5 years or 3 years, you say, well, look into it.
There certainly may be better choices, and for a lot of people, if they go to see their doctor, if they feel it's adequate. I mean, and we get that too, where we'll talk to patients, we'll say, well, you're on this, but there may be something better. Sometimes it's like, well, I'm familiar with this drug, and I'd like to continue it.
Okay.
But there are things that can be done that can just improve. So many of the advances are improvements on what you've been used to.
Do you ever see patients come in with medications for pain, and then you just shake your head and go, wow, These people, this is just old. You know,
well,
it's outdated.
Well,
do you see that?
That does occur occasionally, particularly in the.
I mean, you're trying to be nice right now, but
well,
do you see it a lot?
I would say no, we don't see that a lot.
Weekly?
But where we do see, yeah, probably weekly.
Well, that's a lot.
But where we do see it is, you know, kind of the understanding of pain. Pain is not just all one thing. It's not all the same receptors. You know, if you hit yourself with a hammer, and your tissues are damaged, that causes one type of pain. If you have shingles and the nerve is infected, that's a different type of pain. Narcotics will work for one but won't work for the other. So in particular, there are, you know, really probably over the last year, maybe 20 new drugs that actually can be used for these nerve type pains. But in the old days, there was really sort of just narcotics. And so, you know, those are the cases where you look at it and you kind of go, boy, you know, we can do a lot better for you with a lot of things. And those patients have come in because, you know, they were taking 3 Vicodin a year ago, now they're taking 10 Vicodin, and, you know, they're getting concerned about the medications and so on. Or quite often the physicians will send them, they'll say, this patient's getting a little out of control. What else can you do for them?
So what do you say then? Somebody watching this, they haven't seen their pain doctor or had a
or they don't
assessment of their meds, et cetera.
Right.
They don't have a pain doctor.
Right.
And it's been a year. They should see you.
Well, I think, you know, with anything, if you were taking antihypertensive and you know, either it wasn't working well or there's question about, you know, there's side effects with all the medications, maybe there's something better that can be done. And so I think it's worth just finding out if there's something that can be done that would improve the quality of your life. That's really what we're about. Okay, great. I want to thank you for coming on the show. Always a pleasure. And we'll have you back to talk about some of the other procedures you do, and also we're going to have to do an on-site over there, and you kind of show me around because that's a big facility. Great, getting big and getting bigger with more offices all the time. Okay, great. Okay. You've been watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. If you'd like to see this program again online, visit our website at wellnesshour.com. For now, I wish you good health.